All right, well, I appreciate the invitation again from Dr. Swigart and the UNC faculty to bring me back again. Every year I come back with a little bit more gray hair, and another year in North Carolina, so I think every year I speak a little bit slower. I don't know. You guys can tell me whether that's true. So this is my disclosure slide. I think they also have that in the book. So basically, I think over the next 35 to 40 minutes or so, they asked me to kind of focus on the treatment of HCV, and in particular a focus around HCV and the AASLD-IDSA guidelines, which hopefully everyone in the room is aware of. But let me see a show of hands. How many of you know that there is a guideline online living document for guidance for providers who treat Hep C? Excellent, great. So for those of you who don't know, HCVguidance.org is a great website. Again, focused really around the DHHS, HIV, adult and adolescent guideline, updated on a very regular basis to keep up with the amazing pace of HCV treatment and drug development. And what I really want to focus on is the treatment of HCV patients, really going through the guidelines and what's offered within that document for everyone. So this is an excerpt that I pulled out just to bring home the point as to why we would focus on the treatment of hepatitis C, which it says here, the goal of treatment of HCV-infected patients is to reduce all-cause mortality and liver-related health adverse consequences. So people may not realize, but having HCV increases all-cause mortality, not just liver-related disease, not just need for liver transplant, but death for other causes. And that is because I think we have in the past grossly underestimated the fact that while HCV causes liver disease, it also causes pretty significant extrahepatic disease. Not just the ones that we learn about in internal medicine, but pretty significant neuropsychiatric disease, bone disease, insulin resistance, risk of cardiovascular disease and strokes. And I think this is something that really plays into that increased all-cause mortality that we see for these patients and really argues for why all people require treatment for hepatitis C regardless of the stage of their liver disease, which is what you see here in terms of the recommendations on who to treat. The recommendation is that everyone should be treated regardless of the stage of their liver disease. And I think that's a point that's really critically important. So the other thing that this says is that the way that we assess cure is by this term that we use, which is sustained virologic response, or SVR. So sustained virologic response previously was characterized or defined as having an undetectable viral load 24 weeks after you've come off of HCV therapy. So remember that HCV therapy is a finite period of time. Current guidelines recommend anywhere from 12 to 24 weeks of treatment for attempts to eradicate HCV. So this is not a lifelong therapy. And ultimately, the way that we know for sure if someone's cured is if you stop the drug and there's no more drug pressure and the patient's still undetectable 12 to 24 weeks later, they are in fact cured of this virus. It is a virus that we can eradicate from the human body. And that really makes it very, very different than many of the viruses that we all deal with clinically, where there usually is a latent and an integration phase. And so with HIV or hepatitis B, herpes viruses, there's really not much chance to get that virus out of the host genome. So the title of this was the top 5 things to remember about HCV treatment. And I might have gotten carried away. There might be a number 6 or number 7, because every time I kept going, there are more slides to make. But I try to focus on 5 main points around HCV treatment for those of you who are doing this today. So one is that staging of liver disease still matters. And what does that mean? You know, in the old days, when we treated HCV, the treatments were difficult. So interferon-based injectable therapies that had a pretty significant side effect profile. In addition, we used ribavirin, which involved up to 6 pills a day, also a pretty significant adverse event profile. And so one of our main decision makers and one of the main reasons that we used liver biopsy was to decide whether or not it was worth it for the patient to take the therapy. Was the risk of treatment outweighed by the potential benefit? And back in those days, we used to say that if you were F2, 3, or 4, and this is the way that most pathologists will stage liver disease. This is a Medivir scoring system. So this is moderate fibrosis, severe fibrosis, and F4 being cirrhosis, that those patients had room to benefit from eradication, even in those days when chance of eradication was only about 40% for a genotype 1 patient. Whereas F0, F1 could wait, and the idea behind that was wait for something better. So clearly something better is here, right? Now we have multiple fixed-dose combination pills that cure hepatitis C at 98 to 99% in 12 weeks. To be fair, from an efficacy standpoint, it isn't going to get much better than that, and they're amazingly safe and well-tolerated for patients as well. So the question is no longer, do they need treatment? Everyone would argue that they absolutely need treatment. The real question is, do they have cirrhosis? So in the time that they've had this viral infection in their liver, had they suffered significant liver damage? And if that's the case, how reversible is liver damage in a patient with hepatitis C? So we're not going to get into this into great detail, but in Hep B, we know if you take a patient with Hep B and cirrhosis, you give them a nuke, like entecavir or tenofovir, and you treat them. 5 years down the road, over 50% have had regression of their cirrhosis. It's really unbelievable. That is not true in hepatitis C. So if you look at paired biopsy studies in HCV in patients who achieved cure in the interferon era, less than 20% of people after 3 years had regression of their cirrhosis. So cirrhosis in HCV is much different than cirrhosis in hepatitis B. Regression is significantly slower. It is not universal. So I would argue when you go into this in a patient who's F3 or F4, you have to presume that they're going to have cirrhosis for at least the next 10 years of their life. Quite possibly, and most likely, even longer, right? So I always say, at least for the current data, once a cirrhotic, always a cirrhotic. So even if you're going to cure them, they still need to have ongoing liver disease management. At a minimum, liver cancer screening, possible esophageal varices screening, depending on how severe their portal hypertension is, et cetera. So that's a critical point for us to continue to think about. And then also, as I mentioned, prior therapies or current therapies, it still matters for some of the regimens, and we'll get into this, whether or not you have cirrhosis. So you may treat a patient differently if they have cirrhosis, and what you don't want to do, in my opinion, is undertreat a patient, increase their risk of relapse, especially in a cirrhotic patient, where I've had patients in the interferon era who relapsed cirrhotics, who decompensated in the setting of their flare of their HCV at the time of relapse. So certainly not something that we want to have to think about. So there are alternatives to liver biopsy. And believe it or not, these have been around for a very long time. Most of us didn't use them because their main limitation is that they cannot differentiate different stages of liver disease. So they cannot differentiate an F1 from an F2, from an F3, from an F4. And back in the day, that was the question we needed to ask, right? Are they F01 or are they F23? And that was something that these tests could not do very well. But what the test can do with a better performance is to tell you whether or not someone has cirrhosis. And to be fair, that's really what you want to know today is, does my patient have cirrhosis, yes or no? And in that setting, the performance characteristics of this test goes from previously being able to give you a 60% correct answer to a 90% correct answer. 60% not good enough for clinical practice, 90% certainly better. And I think for most of us, we're willing to live with it. So this just shows you some of the standard markers that we all use, a pre-score or FIB4. These use clinical markers that we already have available, age, AST, platelet count, ALT. There are also more expensive tests that are commercial tests, like a FibroSure in Europe is called a Fibro test. And then we also have some radiologic tests, in particular elastography, which for the folks who are in the afternoon, or the morning session, or afternoon, I don't even know, the noon session. Everyone was eating lunch, it must have been noon. I heard already that these are some radiologic types of non-invasive tests that I think when you have two and there's concordance makes you feel more confident that you're making the right decision regarding staging this patient's liver disease. There are plenty of people who fall in the middle, and in that setting, you either have to use your gut, which is what I do a whole lot of, or you have to go to liver biopsy. And so liver biopsy hasn't gone completely away, but we're certainly more tolerant of using some of these non-invasive tests given the changes in the question. So this is the elastography, and I know that at UNC there's a FibroScan, which is a specific type of elastography. Duke has a FibroScan. Many of the VAs have FibroScans. You know, Dr. Hurt brought up earlier that in addition to an actual FibroScan machine, There is elastography that can be done with ultrasound technology and with MRI technology. So there are many clinics that don't have access to FibroScan, or their patient doesn't want to drive 2 hours to UNC to get a FibroScan, but you can work with your radiologist to develop the technique to do ultrasound elastography. And I know that there are many groups that practice in North Carolina that have that because they call me with the result or they refer a patient in with the result. So I know folks are able to get that, and I would generally think that a radiologist is more than happy to work with you to create a new test that they can bill for. And it is billable and insurance pays for it, so it seems like it's a good conversation to have with a radiologist. So I would certainly encourage you to consider that, even if you can't get your hands on one of these FibroScan machines. So the other thing that I feel is worth mentioning is, you'll see this a lot in terms of reads from radiology. So ultrasound, CT, MRI, without elastography built into the technique, are used to screen for liver cancer in patients with cirrhosis and HCV, or Hep B, regardless of cirrhosis, because Hep B is a carcinogen in and of itself, right? So I feel like many people sometimes say, and even radiologists like to say, heterogeneous tissue concerning for cirrhosis, nodular liver, morphology concerning for cirrhosis. I can tell you that radiologist is just making that up. And without something more specific, you cannot take that to the bank. You also can't take to the bank that they say, homogeneous tissue or heterogeneous tissue and smooth contour. That doesn't mean anything. That patient can totally have cirrhosis. So you do not use these tests to determine whether or not someone has fibrosis or cirrhosis, no matter what the clinical report or the radiologic report says. You use them to determine whether someone has a liver cancer. Now, there are some very specific things that you can see that are convincing. So if a patient has nodular contour and an enlarged caudate lobe or left lobe of the liver and splenomegaly, all right, I'll give you that. Over 90% specific for someone having cirrhosis. Esophageal or gastric varices on imaging, I'll buy that as well. Although we do know that there are cases of non-cirrhotic portal hypertension, DDI, for example, but I think less common. So there are some very particular things, but those are few and far between. So just remember that these are not things these are not tests that you use to make a diagnosis or to stage liver disease. All right, so when it comes to talking about HCV in patients that have HIV, I think this is now over 2 years old in terms of what the AASLD/IDSA guidelines say regarding treating patients with HIV, which is there is no difference to treating a patient with HIV for hepatitis C other than the fact that they are on antiretrovirals, and you need to think about what those drug interactions are and choose regimens that are compatible. Because the last thing that you want to do is sacrifice the patient's HIV control, increase risk of toxicity. And I think this becomes all the more relevant. There are lots of drug interactions, but when you're talking about antiviral interactions, it means that there's a potential for loss of viral control. And that means more to me than loss of someone's cholesterol control, or even, I hate to say this, and I'm an internist, blood pressure control, because there may be more of a price to pay if you are putting this patient at risk of HIV failure, right? So when it comes to antivirals, I do think that they carry more weight and are more relevant when it comes to drug interactions. So we're going to talk about we're going to talk about all of the drugs that are currently FDA approved and a few regimens that are not yet FDA approved. So to take a step back, I know this is an HIV audience, but we're going to talk about the mechanisms of action. For those of you who have been here the past few years, this is a very familiar slide because I think I've used it every year. And amazingly, really, the mechanisms of action have not really changed clinically as of yet. So again, these are targeted mechanisms of action for antivirals and very similar to what we talk about in HIV, right? So HCV has multiple proteins that it carries within its genome, structural proteins that are used to form the viral capsid, and then NS or non-structural proteins. And these are the proteins that are the mechanisms of action for the direct-acting antivirals for HCV. We have the NS3/4 protease inhibitors, NS5A inhibitors, and the NS5B nuke polymerase inhibitors. So obviously these two are enzymes, and this is not. It's a protein that's very critical in replication of the viral complex for HCV, and when it's bound by a drug target, it's actually highly, highly active. So what we do in HCV is just like what you do in HIV, which is you combine several of these together. That increases the barrier to resistance, the potency, and you can eradicate the HCV virus with a double, triple combination of these medicines at 98 to 99% across the board. So These are the regimens that you would see if you logged into the AAS or the IDSA website. And a little bit is trying to put kind of a name to the face of the mechanisms that I showed you. And the general take home from this is that you can see, if you go across here horizontally, there are multiple ways that you can do this, right? You can combine, for example, with the cladosphere and sofosbuvir and NS5A and a nuke. With elbasvir and grazoprevir, which comes in a fixed dose combination, you can do what I call a nuke sparing regimen, which is an NS3 protease, NS3/4 protease combined with an NS5A. So much of this, how did this happen? Well, different companies have different drugs. They make them in-house. They put them together. They hope they work. And what we come up with is multiple options that have their own pros and cons. Some of that is cost, some of it's drug interaction, some of it's safety in liver disease, some of it's safety in kidney disease. And based on all of that, you make a decision about which one of these is best for the patient sitting in front of you in your clinical practice. Fewer of these use ribavirin, and we'll talk about that. And I listed here the next regimen that'll be FDA approved in June, because that's obviously very relevant, especially when we talk about non-genotype 1 treatments, and we'll get to that. So this is the way that I break down the approach to HCV therapy, and this still works relatively well, although it's getting a little bit more complicated, is generally to pull apart cirrhosis and non-cirrhosis. And this is genotype 1 only, okay? Because for everything else, it's about to get a whole lot easier. But for genotype 1 only, if you pull apart cirrhosis and non-cirrhosis, then it's pretty simple. You don't have to worry about whether they're treatment naive or treatment experienced per se. But what you can see is if they don't have cirrhosis, you're looking at 12 weeks of treatment for all of these regimens for the vast majority of patients, okay? Some of the regimens still require ribavirin, for example, the PROD regimen for 1As, but not for 1Bs, right? And you can see here there's a couple of asterisks here. So some of these regimens, the single asterisks, these regimens are approved not just in PEG-RIBA failures, but in prior protease PEG-RIBA failures, right? And in fact, this is a protease-sparing regimen, so it makes sense it would work well in a PI failure because of resistance. But this is actually a PI-containing regimen, but it's a next-gen PI, so it doesn't have the same issues regarding resistance from prior PI-failed regimens. And you can use this, but with this regimen, you do have to use ribavirin. So it's 12 weeks, but it's 12 weeks with riba. The ledipasvir sofosbuvir regimen is also, again, PI-sparing, approved in protease inhibitor failures, as well as sofosbuvir failures. So when sofosbuvir was first approved, it was approved either with PEG-RIBA, as were many of the first wave DAAs, or with ribavirin alone. So if a patient had failed that prior regimen, you can in fact re-expose them to that nuke along with another DAA because that nuke has such a high barrier to resistance, and you can rescue them. This also, however, if it was a PI failure, would require ribavirin. So you can see it's 12 weeks. There are some caveats, but it's relatively simple. And then here you can see one exception with this elbasvir grazoprevir regimen is 1As. You do have to do NS5A testing, and we're going to spend about 6 slides on this because this really is an emerging issue that is pretty, in an HIV audience, is pretty easy to talk about, but there are some caveats that are counterintuitive to those of us who have done HIV for most of our careers. But still relatively straightforward, a lot of good evidence to support 12-week regimens for non-cirrhotic patients, right? So this one slide, so this is point number 2. So remember, point number 1 is liver disease staging still matters. So point number 2 is, you guys know this, HIV is no longer a risk factor for poor response to therapy. Duh, right? This is, we're just going to, every year I'm going to have the same slide. I'm going to keep putting it up and just adding different studies to it. But you can see here now for the majority of our approved regimens, the Daxoft, the elbasvir grazoprevir, Ledsoft, PROD, and now even the coming regimen of Soft-Vel, you can see that patients with HIV in blue versus HCV mono in red, there is absolutely no clinically significant difference here. Some differences in population, clearly. And even in what I would say is the largest real-world cohort out of Europe, showing there is no difference when you treat patients with HIV. So this really, the playing field is leveled for HIV patients. You just have to be smart about how you combine these regimens when it comes to the drugs. And this makes most people who don't do HIV run away. And or someone just totally checks out at this point, right? But there's lots of colors, so it's kind of nice. So this is, however, the reality of treating patients with HIV, okay, and HCV. So this shows you, I couldn't put all of the regimens on here, but what I would kind of argue are the most relevant regimens based on cost and what you can actually get your hands on today. So this is the elbasvir-grazoprevir regimen, a protease inhibitor containing regimen, the soft Velpat regimen, which is an NS5A, and we're going to compare and contrast these two. Not yet approved by the FDA, will be approved in June as a pan-genotypic regimen. The lead-soft regimen, you can see here, by far from a drug-drug interaction perspective, what appears to be the cleanest, right? And then the PROD regimen. So and the folks who are in the lunch session, protease inhibitor containing, red, right? That's going to be the issue. Moving forward, I can tell you that 2 years from now, we are likely going to be using either triples that include protease inhibitors or duals that include protease inhibitors, which means it is likely that this is just going to get uglier, not better, when it comes to the drug interactions for HIV patients, okay? So I'm not going to belabor this point. The grazoprevir can be used with ropivirine, raltegravir, dolutegravir. Those are your anchor drugs. You can see that the PROD regimen can actually be used with the atazanavir-based regimen. The darunavir-based regimen came up in the afternoon session. It is likely that this will turn green once the phase 3 study is completed. Darunavir levels definitely decrease in the phase 2 study, 50 to 60%, or so it's 40 to 30%. But ultimately, whether this means increased relapse for HIV yet does not appear to be the case. So I think as long as the phase 3 studies support this, this will be a little bit better. And then what we're going to focus on here is the NS5A sofosbuvir regimens, where you can see here that with this new NS5A, there is an issue with efavirenz and etravirine. So this is going to shorten or at least contract a little bit the HIV regimens that you can use. And then we're going to talk about this issue, which I think has been the primary issue with this regimen, which is the increase in tenofovir exposure. So if you use either Velpat or ladipasvir, wish a patient on tenofovir, TDF tenofovir, there are pretty significant increases in tenofovir exposure, specifically when patients are on boosted regimens with either COBI or ritonavir. That does not play out as big of a deal for patients on efavirenz or ropivirine or an integrase inhibitor, but on these boosted PIs in particular. So this shows you the data from the lead-soft trial, and I think there's a couple points that you can use to talk about HIV in particular. It's related to this study, but it really is true across the board in HIV-infected patients. And that is what we learn in drug-drug interaction studies in healthy volunteers does not always translate into what happens in patients who have active HIV, active hepatitis C, and in particular, active liver disease. So there are a couple of things that we saw in these studies. One was that ladipasvir levels were lower in patients on efavirenz. These are in healthy volunteers. And that tenofovir levels were higher in patients on efavirenz and ropivirine. In fact, based on these studies, some people were taking patients off of efavirenz to give this regimen. And ultimately, in the study that actually looked at patients with the infection, in fact, patients on ropivirine had the highest tenofovir exposures, and patients on efavirenz had the lowest exposures. And so I think time and time again, we have to remember that healthy volunteers does not translate into real clinical practice and into real patients. So we have to be very careful about extrapolating healthy volunteer data into our clinical practices. So I think the phase 3 study suggested that these levels of 3,600, 4,300, 4,000 AUC for TDF or tenofovir was not a major issue in terms of risk of toxicity to the kidney. But what we didn't know about were the increased exposures with boosted protease inhibitor regimens. And what I'm going to show you here is if you look at what we see in HIV clinical practice with tenofovir exposures in TDF-containing regimens, we have all known that boosted protease inhibitors in patients without hepatitis C on no hep C drugs have increased exposures, right? We do it in the clinic all the time. We monitor their kidney function. We don't get too worked up about it. When you look at how ladipasvir, when combined with one of these three, ropivirine, efavirenz, or raltegravir, you can see you get pretty similar exposures to what you're used to in HIV patients without hepatitis C on tenofovir-containing regimens. What we don't know about is the safety of these regimens, and that's a boosted PI plus tenofovir plus ladipasvir, right? These patients were not included in the phase 3 study. And based on the package insert, based on all the guidelines, it says you should switch, if you're going to use this regimen, you should switch these patients off of TDF, right? Or don't use this regimen, or off of the boosted PI if you're going to use it safely, okay? Do we have more data now? The answer is maybe. So what I'm going to show you is data that was presented by David Wiles at the liver meeting, 2 weeks ago now, of the soft Velpat regimen. Velpat is also known as 5A, as I mentioned. As you saw on that really complicated drug interaction slide, it also increases TDF, tenofovir exposures with TDF. And in fact, they did enroll boosted regimens. In fact, over 50% of the regimens enrolled in this very small phase 3 trial, N equals 106, over half were boosted regimens. Either they were TDF, boosted with either Cobi or ritonavir. So you can see that the boosted regimens were in the light green here, okay? The non-boosted TDF regimens were in the dark green. And the non-TDF regimens, so these are people who are on presumably a bacavir and 3TC, are in light blue. So there's a couple of take-homes. One is that, as you can see, all patients had GFRs greater than 60. So the bottom line is if you're going to use this Ledipasvir soft regimen or the Velpat soft regimen, you have to do it in patients who have normal baseline kidney function. All bets are off as to the safety if you get increased tenofovir exposures in a patient who does not have normal renal function. So that is caveat number one. So then two is, you can see, interestingly, the patients who were not on tenofovir-containing regimens had lower GFRs coming in. Presumably, that's provider bias, right? You don't put someone on tenofovir who already has a GFR that's lower. So that's presumably these patients had some sort of baseline kidney disease, and that's why they were not on a tenofovir-containing regimen. But you can see that there was no clinically significant change. A slight bump of about 9, I think, mils per minute here. They rebounded about midway through therapy. There was no difference. So no safety signal at all, which would argue that it is likely that this would be true for Leadsoft, since essentially the increased exposures to tenofovir are about the same. So I think ultimately, hopefully, we'll see guidance providing some input on what you can and should do with the Ledipasvir regimen in patients on boosted regimens with tenofovir moving forward. The other thing I think is important to know is that we do at least have healthy volunteer data, again with a caveat, of the TAF-containing regimens. You all know that the exposures to tenofovir with the TAF-containing regimens is over 10-fold lower, and so there's no issue with TAF-containing regimens. So ultimately, moving forward with these increased exposures do not play out when you start using a TAF-containing regimen. And that will make all of our lives a whole lot easier when it comes to thinking about the complexities of using those two regimens in particular. So more in line with the drug-drug interaction story. So I think it's really important that while we focus on drug interactions around the ARVs, there are many other drug interactions. And some of you guys heard about some of these this afternoon. Statins, I mean, when it comes to calcium channel blockers, antidepressants, I mean, when you're using these, Lexicomp interactions is like on my desktop, and every patient I treat, I type in every drug because I don't want to make a mistake, and I can't remember everything. So I do that, but I think this is one that I pull out as being a big issue because use of acid suppressants and PPIs is rampant, and because they're over the counter, lots of patients take these medications. It doesn't show up on their MAR. No one knows they're taking them, and I think it's really important for everyone to recognize that when you use a PPI in the setting of a ledipasvir-sofosbuvir regimen, there is a concern for higher risk of relapse. You can see here in a real-world cohort, patients who received this regimen and are on PPIs did have higher relapse rates. Presumably, this is because of a decrease in absorption of the ledipasvir, decrease in exposures to the ledipasvir, and a higher risk of failing. So my clinical practice is to take all patients, if I'm going to use this regimen, all patients off of acid-suppressing medicines, period. I would generally be nervous about using a PPI in particular. TOMs and H2 blockers are probably okay as long as you dose it exactly as per the package insert. But with PPIs, I would seriously beware, and I would even consider using a different regimen if you had that option, because risk of relapse seems to be a concern. The odds ratio was 2.4, higher chance of cure if you weren't on a PPI. So I think this is an evolving situation, but for now in clinical practice, something that you should be aware of. I also raised this in an HIV co-infected patient because there are some concerning reports that patients with HIV co-infection in particular have lower ledipasvir exposures to begin with. So this shows you from the phase 3 trials and 3 trials for Ledipsoft in patients who have HCV only, that the exposures to ledipasvir in the phase 3 trial was about 6,000 versus 8,500 in the phase 2-3 for patients with HCV monoinfection. So for some reason, HIV patients have lower lead exposures to begin with. Then if you throw in the issue of a possible lower exposure given acid-suppressing medicines, atrophy of the gastric mucosa, et cetera, I think HIV patients in particular may be higher risk for this. And no one has reported on this yet, although that's probably going to change relatively soon if my IRB can move quickly enough to try to understand this. But I think this may be relevant in particular to HIV-infected patients. I think it's also concerning. We have no idea why this is. And I think this is why continued studies in phase 3 trials in HIV patients will remain very, very important to understand why these exposures exist. These differences in exposures exist for all of these regimens in particular. So now I wanted to move into another kind of general special population, and that's renal disease. So a lot of our patients have comorbidities, diabetes, hypertension, CKD, and increasingly this becomes a concern. So I think it's important to think about what your different options are when it comes to HCV therapy of patients who do have significant liver damage. So this gives you a summary of the various regimens that are currently FDA approved and where we stand with regards to safety in renal disease. So ribavirin, everyone knows, is renally cleared. It's a major issue. You can use it in patients with significant renal disease, but you have to proceed with caution. There are significantly lower doses. These patients are at very high risk for developing significant anemia. And of course, patients that have significant kidney disease are higher risk for cardiovascular disease and certainly are at higher risk of inducing a myocardial infarction or a stroke, which has clearly happened in patients on ribavirin when they're not closely monitored. So this is an issue, and this is extensive data supporting its concern for safety in patients that have significant renal disease. So sofosbuvir is renally cleared. I have an asterisk here because it really is primarily its metabolite. It's inactive metabolite that's renally cleared. And for that reason, FDA says you should not use it in GFR less than 30. And remember that with tenofovir, you shouldn't use the soft lead combination in patients who have a GFR less than 60. So that's really important to remember. The protease inhibitor, so if you look at, it's really the nuke. If you look at most of the protease inhibitors and even the NS5As by themselves, they are not renally cleared. So technically, they should be perfectly safe in these patients. The issue is if they're combined with sofosbuvir, cimipravir, ladipasvir, declatosphere, then you have to default to its use with sofosbuvir, which now gets you back into the you can't use if the GFR is less than 30, right? The PROD regimen is an interesting regimen. It is not renally cleared. It is not approved either because there is little data, but there is the RUBY-1 study of 20 patients showing that it is quite safe and highly effective. So it is my backup. When I go to a patient with renal disease, I go to the FDA-approved regimen, which is this regimen that I'll show you the phase 3 study on. It's the only phase 3 study in patients with severe CKD and stage renal disease. But there are times when you can't use this regimen, as we'll get into, and when that's the case, this is my fallback when possible because it's not renally cleared and it doesn't include the sofosbuvir where there is clearly less data. So this is the elbasvir-grazoprevir phase 3 study called the C-SURFER trial that was the first phase 3 study done in patients with severe CKD and stage renal disease. And I would say that this was a huge step forward for patients with chronic kidney disease. Given the issues around ribavirin and interferon and poor response to therapy, this is the first FDA-approved regimen specifically in patients with CKD and end-stage renal disease. And you can see that there was, out of 116 patients, only one patient relapsed in this regimen. So we're going to get to this when we get to NS5A resistance, but it's probably worth talking about here. This is also the regimen I mentioned when I showed you the 12-week, everyone gets 12 weeks of therapy, right? With the caveat that with this regimen in 1As, you have to check for resistance. And a patient who has resistance, who's a 1A, and we'll talk about what that is, would require either a different regimen or extension to 16 weeks plus ribavirin. That is what the FDA says, okay? That you test it regardless of whether they have kidney disease or not, and you give them 16 weeks plus riba. And if you aren't comfortable using riba in an end-stage renal disease patient, then you need to find a different regimen, right? So interestingly, that's not what the data supports. And this is one of those areas where the AS or the IDSA guidelines actually branches off of what the FDA package insert says. The recommendation for a CKD end-stage renal disease patient 1A by the guidelines is you do not test for NS5A resistance because there is yet evidence that NS5A resistance predicts failure. Why is that? Could be a numbers game. The more people we treat, the more we may find that we are wrong. It could also be because these patients do have higher exposures. Even though they are not predominantly renally cleared, there is some renal clearance component, and these patients do get higher exposures to these drugs. And that may be enough to beat out these resistant variants. Something that sounds totally crazy to an HIV audience, because that is not what happens in HIV, but in HCV, this is the reality of resistance, and we'll talk about that more extensively in the next few slides. So the next point to make is around shortening of therapy, and I don't want to belabor this point, but for many of you who are writing these prescriptions, you know that the ledipasvir sofosbuvir regimen is approved for 12 weeks. However, there is a caveat for the FDA that you could consider as the provider to shorten therapy for 8 weeks in particular patients. And the question is it the provider's decision or is it the insurer's decision? Because as you all know, at least in my clinical experience, it has not been my decision. I ask for 12 and I get 8. I beg for 4 more, I get denied. So this is an issue that's been turned around and has been used as an actual ultimatum in terms of length of therapy for patients with HCV. So this is the study that kind of looked at the idea of 8 weeks. This was in HCV mono-infected patients. The cure rates in the first treatment-naive trial for this regimen was 99%. So it does make sense that you would say, wow, if we can cure 99% in 12, surely we can cure 99% or 98% in fewer, right? So this is what the purpose of this trial was. And if you look at these numbers, you'd argue that 8 weeks, with or without ribavirin, was the same as 12, right? But if you look at relapse, which is what matters clinically, right? Did the virus stay away? That's what we care about clinically. The answer was no. So 20 relapses versus 3. So the general take home here is shortening therapy increases relapse. That's all there is to it, right? Can you pick a particular patient population where maybe you can predict that these patients will not relapse? So the FDA says that in patients with viral loads less than 6 million with this regimen, right? This is the ION3 trial with this regimen, that those patients achieve 98% cure with 8 weeks versus 12, no difference. This is the patient population that you can identify as having a same cure rate, and you can shorten therapy. You, the provider, can make that choice. What about in HIV patients? In HIV patients, there was one study that a priori looked at 12 versus 8. Now, they didn't just do treatment-naive, non-cirrhotic, easiest to treat. They actually lumped in treatment experience and cirrhotics, but very clearly, again, it's the same story, right? 10 relapses versus 1. Shortening therapy increases relapse, okay? So this is actually a heated topic, and in fact, sitting on the guidelines, I can tell you that we take a lot of heat for not recommending 8 weeks for patients. And if you look at the real-world cohorts, in fact, there is a pretty good argument for 8 weeks working very, very well. The Target, which was the cohort I showed you that had the proton pump inhibitor data, reports 97% SVR in their 154 patients who got 8 weeks. Another large real-world cohort, 95%. That European cohort that I showed you, 92%. And in the HIV patients who got shortened, it was exactly the same. It's cheaper. That's good, I guess. So ultimately, this is the argument that people make for why. So why do I argue that we really shouldn't be doing this? So number one is, if you go back historically in Hep C, there's never been a single baseline predictor that could truly give you the accuracy and the clinical confidence to make a decision on treatment, okay? If you look at some other real-world cohorts, in the VA, patients that were African descent had higher relapse if they got 8 weeks, okay? The trio, which is right here, if you look at the p-value for the difference in SVR for 8 weeks between African Americans and non-African Americans, it was 0.052. If you're a patient, if you're African American, and your doctor says, I don't think that's not statistically significant, does that matter to you? Matters to me, right? I mean, 0.052, that would take one patient to switch from one arm to another for this to be statistically significant, and then suddenly we're supposed to believe that's clinically significant. I argue that it's clinically significant since this is a cohort study and was never powered to show this, right? And the other issue is that when these patients fail, they fail with resistance. So it'd be different if you had a bailout regimen. Okay, it's cheaper. We treat everyone, and the 6% who fail can get salvaged, and it's 100% cure. But that is not the world that we live in today. We do not have 100% cure salvage for patients who fail therapies right now. And so what we're asking these patients to assume is a risk of failure for which we do not have an answer. And I think that's really problematic. The other issue is if you look at the target, these patients who got a 97% cure, they were only 40% of the people who met criteria, i.e. Geno 1, treatment naive, non-cirrhotic, which means those providers are making an educated decision about who should get access to 8 weeks, right? So remember I showed you the 6 million cutoff for that trial? That's what the FDA says. Use 6 million and you should be okay. So Tom O'Brien's group went back and took all that data, and instead of looking at viral load, they looked at other clinical characteristics, the way that we normally do clinical research, right? A multivariable analysis, not pick a viral load and see if it sticks, okay, which apparently is what happened here. So if you look at all the clinical predictors in that same clinical trial, 3 things come up. Women are more likely to achieve cure with 8 weeks. African Americans are not. And patients with IL-28 TT are not, which we know is more common in patients of African descent. So this clearly supports that this is not as simple as a single viral load test. So clinically, I would argue, until there are a priori randomized controlled trials showing this in a diverse patient population that well represents patients that are not just white non-cirrhotics, then in your clinical practice, I would beware. So does that mean 8 weeks is gone forever? So this actually shows you data that just came out of the European Liver Meeting showing you the next generation. This is a non-improved investigational combination of an NS3-4A protease inhibitor and an NS5A. And it shows you that 8 weeks, a priori randomized controlled trials, right, shows you that, in fact, 97, 98, 93 in genotype 1, 2, and 3 non-cirrhotics. And this one patient, and this one patient were not relapse. There were no relapses in 8 weeks. So is 8 weeks coming? Most likely, but not in our clinical practice today. These regimens that we're using today were not designed to cure patients in 8 weeks. So this is a summary of how we treat patients with cirrhosis. So remember what I showed you before was all patients without cirrhosis. When you start getting into patients with cirrhosis, it is not as pretty as the first slide, right? It's not 12 weeks all the way down. But I think the good news is that there are multiple regimens where 12 weeks is still the standard of care. In fact, there are 2 regimens where 12 weeks, regardless of prior treatment experience, is the standard of care. And that is the elbasvir-grazoprevir regimen, right? So if you're not a 1A with an NS5A RAB, then you get 12 weeks regardless of whether you have cirrhosis, treatment experience. Remember the one caveat, if you're PI experienced, you have to add ribavirin to that, but that's actually pretty impressive. If you are the PROD regimen and it's a 1B, 12 weeks. So it can be simple for some of these regimens, but it does get more complicated when you start getting into some of the other regimens. For example, the ladipasvir-sofosbuvir regimen, particularly in treatment experienced patients, you have to either add ribavirin if you want to stay 12 or go 24. So it does become a little bit more complicated, but this table actually summarizes and compiles all of that for you in terms of the approach, right? So you may choose one of these for different reasons based on your particular patient, but it is important to know that it gets a little bit uglier and a little less 12-weekish once you start getting into patients with cirrhosis. Again, how we do treat patients with cirrhosis a little different, at least today, for some of the regimens, but not all. So this is some of the data behind the differences, and I'm actually going to move forward because I want to get into the NS5A resistance story here at the end of the talk. So NS5A resistance, so this is the idea here is, does resistance to one of these particular drugs, whether it's the NS3-4 protease, the NS5A, or the nuke, does it confer risk of failure like you see in an HIV regimen, right? And the answer is yes for some, but not for all. So I think most of this terminology is second nature to an HIV audience. I'm going to go through it very, very quickly just for the sake of if it's not all HIV treaters in the room. But we know, so in terms of a resistant variant, a RAV, we call this a RAV, a resistant-associated variant. What that means is there's a mutation at a site in the genome of that virus that is not the wild type, right? And that confers resistance to a drug. There's all kinds of discussion in the Hep C world as to whether it should be a RAV or a RAP or a RAS. It's really quite amazing, to be honest with you. The FDA calls it a RAP, polymorphism. We call it a RAV, variant. Now people are arguing for an S, substitution. Who knows what we'll be saying next year, but they all essentially mean the same thing to me, which is a mutation in the virus's genome that is not its wild type and that can confer resistance to a drug. We know that generally speaking, for a virus to mutate, to develop resistance to a drug, it takes a hit in fitness, meaning it doesn't replicate as well. So it has to take a hit to get around that drug. That is generally true in HIV in particular. I'm going to show you that that is not true in HCV, which is very disconcerting, to be honest with you. Resistance barrier, you know this well as well. Resistance barrier means either you have multiple drugs, so that in order for a virus to develop resistance to the regimen, it has to develop resistance in multiple genes, or that you have to have multiple mutations in the same gene to develop resistance. This is just like an HIV, right? And then clinical resistance is you actually have to have that on your genotype, and it has to confer failure in your patient. And this is where the translation between HIV resistance and HCV resistance actually has some issues. The other thing I'll talk about is, and I think this is less relevant in HIV. In HIV, we've always used population-level sequencing, right? But in HCV, if you look at some of the talks that are given, people talk about either deep sequencing or what we call next-gen sequencing. This is like detecting variants at less than 1%, which, just so you know, is not clinically relevant, and you really shouldn't pay much attention when companies or groups are presenting data of next-gen or low, ultra-deep sequencing. What really matters is population or Sanger sequencing, and this is usually looking at a variant that's 10 to 15% of the population, okay? So when it comes to NS5A resistance in particular, I can't spend time talking about NS3s, it matters less. Nuke doesn't seem to matter much at all for the current nukes that we have available. But for NS5A, this is really starting to play out in the clinic. And I want to show you how that is playing out. But I think there's a couple things to remember. One is these NS5A variants show up, and they do not take a fitness hit. So these are extremely fit viruses. And from what we can see so far, they're lasting well over 2 years. Still 90% of the population, even when drug pressure has been removed. Totally different than what we're used to seeing in HIV, right? And the other thing that's really crazy is that genotype and phenotype do not necessarily equal. So in an HIV patient with a K103N, you would never use an efavirenz-containing regimen and hope to get away with it. In HCV, you actually can. Sometimes you can do it based on the regimen. Sometimes you just add a little ribavirin or extend treatment, and you can beat the resistant mutant out. And this is something in HIV that just isn't kind of what we're used to in clinical practice, right? So this shows you the current main bad guys in NS5A resistance. You can see that it's different. Again, remember this barrier to resistance? It's different for 1As than 1Bs. It's also different for 3s than it is for 1As and 1Bs. So there's difference for every genotype. And then this shows you the different drugs and compounds. Ladipasvir, ombidasvir, which is in the PROD regimen, declatosphere, elbasvir, Velpat, which I told you is coming. And then here's the ABT 530 that's in that dual regimen that I showed you that works really well, pan-genotypic, 8 weeks in non-cirrhotic patients. So what this shows you is, with our current regimens, you can see that they're pretty much the same when it comes to resistance, right? Really high fold resistance. And so this does apply to some extent across the board. This shows you what a resistance result comes back as, so it's pretty straightforward. Red means no, green means go, and that's pretty much what they give you to understand whether or not you should use the regimen. I will tell you that the labs that make these, or that do this testing do offer patient assistance programs. So you can get this testing for free if you're getting your drug for free through a PAT program. Those same PAT programs exist for these laboratories. So don't use a regimen that recommends NS5A testing because you don't think you can get the test, okay? You definitely should be able to get the test. And this just shows you the clinical take-home. So these are in patients. I'm going to show you 2 different regimens and how this plays out. Declatosphere, NS5A, sofosbuvir, 12 weeks in genotype 3 patients, right? Non-cirrhotics, and I'm giving you 3 mutations, the 28, the 30, and the Y93. And you can see that not all of these RAVs are created equal. The Y93 is a nasty, nasty RAV. So you can see that in a non-cirrhotic, these RAVs don't matter as much. This RAV does. This isn't a treatment-naive patient who has this RAV at baseline. And if you have that RAV and you get this treatment for 12 weeks, you have a 67% chance of cure. If you're a cirrhotic and you have these, your chances are 20 and 25%. So baseline resistance does confer failure to this regimen in genotype 3 patients. Similarly, with the elbasvir-grazoprevir regimen in 12 weeks, this shows you why the FDA made the recommendation of doing NS5A testing at baseline. If you look at a 1A in particular, baseline RABs are only 12%. So thankfully, it's not common. It's a minority of the patients, right? If you don't have a RAB, that's 88% of the patients. Here's the cure rate, 58 versus 99, right? So while it's only 8 of 19 patients, if those 8 are one of your patients, they don't want to assume this risk, right? So what the FDA says is you check for this at baseline, and if they have it, then you either give them 16 weeks plus riba, which appears to rescue this RAB and have 100% SVR, or if you can't use ribavirin for some reason, then you choose a different regimen, okay? This doesn't play out as much in 1Bs. You can see here very small numbers. 1Bs, it doesn't matter as much, so it's not recommended. And the reason that this is the case, I believe, is that this is, remember I told you that 1Bs have a higher barrier to resistance than 1As? So if you have an NS5A RAB, the PI can bail this regimen out better than a 1A. And I think that's probably the general reason for that. So this is not necessarily true in other regimens. So in a regimen, I showed you that Daxoff, genotype 3, it matters. What about in genotype 1 with a lead-soft, essentially the exact same regimen, just different companies? Treatment-naive patients get treated for 12 weeks. You can see there's no difference based on NS5A RAVs. But pretty clearly, if you tried to shorten therapy, the RAV matters, right? And if patients are treatment experienced, the RAV matters. So in this regimen, RAVs matter, but they matter in a subgroup of the patient population. And most people believe, based on the data, that that is primarily in treatment-experienced cirrhotic patients. And remember, in treatment-experienced cirrhotic patients with this regimen, we don't use 12 weeks, right? We either add ribavirin or we extend therapy, which improves SVR, decreases relapse, and essentially address the RAVs without knowing it, if you will. And so I think every group and every study has managed ways to address these RAVs. And that is why RAV testing by the FDA is not recommended for some of these regimens, but is recommended for others. All right, so I'm going to skip through this. So in the last slide, this is just to show you, so what about, there's more than just genotype 1, right? What about genotype 3 through 6? So as of today, I would argue that you're not treating a 2 or a 3 or a 4, 5, or 6 because you know that this regimen is coming. And this is the soft Velpat regimen. It'll be what people believe will be the first approved pan-genotypic regimen. There are other regimens. Daxoff is approved in Europe in 1 through 4. It's approved in the US here in 1s and 4s and 3s. 1s and 3s. But ultimately, it is likely that this will be the first regimen truly approved in 1 through 6. And this shows you the phase 3 study of 624 patients. 1A, 1B, 2, 4, 5, 6. There were 2 relapses total. Right? So the new standard of care, I would think, for a 2 clearly is this regimen. For a 1, my guess is it'll go in the mix with all the others, but you'll have to make decisions on how to use it. But for sure, with these regimens where we have very little data, I think ultimately this will become a preferred regimen as a single fixed-dose combination pill. This included cirrhotics, it included treatment-experienced patients, it included all of that. What about genotype 3? Now the most difficult to treat genotype. As you can see, compared to what is considered one of the current standards of care, which is sofosbuvir and ribavirin alone, which is in blue, as you get into cirrhotic patients, you can see that this regimen started to fail relatively miserably, but this new regimen that's going to be approved in June does better. I would argue that you still get relapses in this cohort. So I think we haven't quite accomplished everything yet, because unless it's 98% or higher, no one's happy in HCV treatment these days. But ultimately, I think this will end up being a preferred regimen for all the non-1 subtypes, which is pretty exciting. All right, so the take home, staging of liver disease still matters. Cure for HIV-HCV is exactly the same with these DAAs, and I don't foresee that changing ever again, I hope. Shortening therapy with our current approved regimens increases relapse. I don't care, what people want to say. I just refuse to believe it. So I would recommend 12 weeks in all of your patients for now. Cirrhosis for some regimens, not all, does require extending therapy or ribavirin. So just remember that's why assessing cirrhosis is so important and making sure that you know and then you make that decision based on the regimen. You don't want to undertreat these patients. NS5A RAVs do matter. They matter certainly for retreatment and for some regimens in particular for initial treatment. And the pan-genotypic regimens are coming. I showed you the dual. That looks really fantastic. It'll probably be approved in 2017, and then the Abbott dual, and then the AbbVie dual, and then this regimen will be approved in June. So I think some really exciting stuff moving forward in the next 2 years. And I think this is my going away slide. You guys maybe remember this from last year. It says the only treatment option he had under his current health care plan. And I think we continue to have many patients who waited forever to get HCV treatment. We told them to wait. They look at you like you have 10 heads when you tell them they have a curable illness, but their insurance won't pay for it. And there's probably one thing that's more painful than telling a patient they've relapsed, and that's telling them they've been denied access of their HCV cure. So this is still something that we clearly need to work on, and that needs to improve until we have universal access for HCV treatment across the board. And that's it, I think.